Welcome, Doctors Hissa. Now that we have covered the phenotypes, let's talk about how these patients actually walk into your clinic. The early symptoms are often subtle and non-specific, which is why the diagnosis is frequently missed. Exertional intolerance, breathlessness, and fatigue is the most common complaint caused by the heart's inability to increase output during activity. However, for many young patients, the very first sign of the disease is an arrhythmia or even sudden cardiac death. Another high-yield presentation is a stroke in a young patient without risk factors, caused by an embolic event from atrial fibrillation or an apical thrombus in the ventricle. When the disease progresses, it presents as the syndrome of congestive heart failure. I want you to remember that congestive heart failure is not a final diagnosis. It is a physiological state. It presents as fluid retention due to elevated filling pressures. If the left atrial pressure is high, the patient has orthopnea and shortness of breath. If the right atrial pressure is high, they develop pedal edema and abdominal fullness. In your exams, do not stop at identifying heart failure. You must use the associated signs, like whether the ventricle is dilated or stiff, to backtrack to the specific cardiomyopathy causing the congestion. The initial evaluation of a suspected cardiomyopathy begins with a rigorous history and physical examination. Your history taking is your most powerful diagnostic tool here. You must ask about a family history of heart failure, but also dig deeper for sudden heart attacks in young relatives, which were likely undiagnosed cardiomyopathies. Look for history of chemotherapy, specifically doxorubicin or radiation therapy. Ask about alcohol and illicit drug use. On physical exam, we assess functional status to see how much the disease is impacting their daily life. These clues help you filter the broad list of causes down to a specific genetic or acquired etiology before you even order an echo. Let's move to the physical examination. In your exams and clinical practice, you must treat the physical exam as a hemodynamic assessment tool, not just a checklist. The jugular venous pressure, or JVP, is your direct manometer for right-sided heart function and volume status. If the JVP is elevated, you have high right-sided filling pressures. Next, assess edema. Differentiate pitting edema, which suggests fluid overload, from non-pitting forms. Also, look at perfusion. The capillary refill time, skin temperature, and mental status tell you if the heart is pumping enough blood forward. A patient who is cold and wet, meaning cold extremities, due to poor perfusion and wet lungs due to congestion, is in the highest risk category for cardiogenic shock. The laboratory evaluation is designed to catch reversible causes and comorbidities. Beyond the standard chemistry panel, pay attention to liver function tests. Elevated LFTs in a heart failure patient often indicate congestive hepatopathy from right-sided failure, not primary liver disease. You must check iron studies, specifically transferrin saturation, to rule out hemochromatosis, which is a reversible cause of cardiomyopathy. Thyroid-stimulating hormone is mandatory because both hyper and hypothyroidism can drive myocardial dysfunction and arrhythmias. Also check the renal function with creatinine and BUN, as cardiorenal syndrome will significantly limit your therapeutic options. In the hematology workup, the complete blood count holds a specific high-yield clue for NEETPG, the eosinophil count. If you see a patient with restrictive cardiomyopathy and marked eosinophilia, your diagnosis is likely Loeffler's endocarditis or hypereosinophilic syndrome. This is a classic spot diagnosis question. We also look at hemoglobin because anemia exacerbates heart failure by demanding higher cardiac output. The erythrocyte sedimentation rate, or ESR, serves as a marker for systemic inflammation. If ESR is significantly elevated, you should broaden your differential to include inflammatory causes like giant cell myocarditis or systemic vasculitis. Infectious etiologies are tested based on specific clinical associations. If the question mentions a patient from South America or a traveler, and you see a dilated cardiomyopathy with apical aneurysms or right bundle branch block, you must mark Chagas's disease caused by Trypanosoma cruzi. For a patient with heart block and a history of a tick bite or rash, think Lyme disease caused by Borrelia burgdorferi. The respiratory pathogen panel is useful during acute presentations to rule out viral myocarditis. HIV is another critical cause. It can cause cardiomyopathy directly through the virus or as a side effect of antiretroviral therapy. Advanced diagnostic evaluation is reserved for finding specific etiologies that change management. We use endomyocardial biopsy sparingly, but it is the gold standard when you suspect infiltrative diseases like amyloidosis, storage diseases, or fulminant myocarditis where immunosuppression is needed. Coronary angiography is performed in almost all adult patients with new onset heart failure to rule out ischemic cardiomyopathy, which remains the most common cause of systolic dysfunction. Genetic counseling and testing are now a standard part of the workup for familial cases, helping us identify heritable causes that put family members at risk. Echocardiography is the gatekeeper of your diagnosis. It is the first line imaging modality because it instantly sorts the patient into one of the three morphologic phenotypes roads: hypertrophic, dilated, or restrictive. On the echo, you are looking for specific parameters: ventricular dimensions to diagnose dilation, wall thickness to diagnose hypertrophy or infiltration, and ejection fraction to assess systolic function. It also evaluates valvular function, as you need to know if that mitral regurgitation is the primary cause of the failure or secondary to the ventricle dilating. This initial scan guides every subsequent step in your management. Cardiac MRI has revolutionized our ability to diagnose the underlying cause because it provides tissue characterization. The most important concept here for your exam is late gadolinium enhancement, or LG. LG identifies fibrosis and scarring. The pattern matters. If the scarring is subendocardial following a vascular territory, it is ischemic heart disease. If the scarring is mid-wall or epicardial, it points to non-ischemic causes like dilated cardiomyopathy or myocarditis. MRI also uses T1 and T2 mapping to detect active inflammation and edema, which is crucial for diagnosing acute myocarditis or sarcoidosis. We are now entering the era of genetic cardiomyopathies. You must understand that the idiopathic label is disappearing. Genetic factors underlie all three major phenotypes: HCM, DCM, and RCM. The prevalence of genetic diagnoses is rising simply because we are testing for them more often. A very high yield fact for your exams is the heritability of dilated cardiomyopathy. While we have known for a long time that HCM is genetic, we now know that at least 30% of what was formerly called idiopathic dilated cardiomyopathy has a genetic basis. This makes family screening absolutely essential. Regarding inheritance patterns, autosomal dominant is the most common pattern for familial cardiomyopathies. This is a key concept for counseling. It means there is a 50% chance of passing the trait to offspring. However, do not forget other patterns. Mitochondrial inheritance is matrilineal, passed from the mother to all children, and often involves syndromic features like deafness or diabetes. X-linked inheritance suggests conditions like Duchenne or Becker muscular dystrophy. Always ask about skeletal muscle weakness in male relatives. When taking a family history, dig for sudden death or early pacemakers, as these are often the only clues to a heritable arrhythmia syndrome. Finally, let's look at the genetic mechanisms, which are becoming fair game for high-level questions. Pathogenic variants usually work in one of two ways. First is the dominant negative mechanism, where a mutant protein is produced and interferes with the function of the normal protein. This is common in missense variants, where one amino acid is substituted. The second mechanism is haploinsufficiency, where a mutation, like a premature stop codon, leads to an unstable or absent protein. So the cell effectively only has half the normal amount. In dilated cardiomyopathy, truncating variants in the titin gene often work via this haploinsufficiency mechanism. We are now moving into the complexity of genetics, specifically heterogeneity and penetrance. This slide explains why two patients with the same disease label can look completely different. First, understand locus heterogeneity, which means many different genes can cause the same phenotype. For example, hundreds of genes can cause dilated cardiomyopathy. Second is allelic heterogeneity, where different mutations within the same gene cause the disease. Most of the variants you will encounter are private, meaning they are unique to that specific family. However, the most critical concept for your exam is penetrance. This is age dependent. A child may carry the pathogenic variant, but have a completely normal heart. The disease expression often develops only as they age. Therefore, a normal echo in a 20-year-old relative does not rule out the genetic carrier state. This leads us to the modifiers of disease expression. Why does an uncle die of sudden cardiac death at 40, while his nephew with the exact same mutation lives a normal life? It is because the clinical course is not determined by the variant alone. It is modified by three things. 1. Other genetic or epigenetic background factors. 2. Environmental modifiers like exercise or toxins. And 3. Sex. We consistently see that penetrance and severity are often greater in men compared to women for most cardiomyopathies. So if a vignette describes variable severity in a family, do not assume there are different mutations. It is the same mutation acting on different genetic and environmental backgrounds. What is the actual clinical utility of genetic testing? For NEETPG, the primary answer is to inform family evaluations. We test the patient to identify the specific mutation so we can screen their relatives. This is called cascade screening. Second, it helps with risk stratification in certain subtypes. And third, and very importantly, it can guide specific therapy. If you identify a mutation for Fabry's disease or Gaucher's disease, you can initiate enzyme replacement therapy. This is a treatable cause. The field is also moving toward gene therapy. So identifying the specific genetic defect is becoming the gateway to future cures. Here is a pathophysiological model you must understand, the two-hit model. This explains why a person who has carried a genetic mutation all their life suddenly develops heart failure in their 30s. The first hit is the genetic predisposition, the loaded gun. The second hit is an acquired trigger that pulls the trigger. This could be a viral infection, exposure to toxins like alcohol or chemotherapy, the hemodynamic stress of pregnancy, or persistent tachycardia. In your exams, if a pregnant woman or a patient with a viral illness develops severe cardiomyopathy, consider that the acquired stressor might have unmasked an underlying genetic susceptibility. Before we wrap up, we need to ensure you are fluent in the abbreviations used in exam vignettes and literature. Do not just memorize the letters, understand the clinical implication. When you see ICD, think prevention of sudden death. When you see LG or late gadolinium enhancement, translate that immediately to fibrosis or scarring on an MRI. NSVT or non-sustained ventricular tachycardia is a marker of electrical instability. And remember the dimensions. LVD and LVDV tell you about remodeling. If these numbers are increasing, your patient is getting worse. If they are decreasing, your therapy is working. Let's consolidate the high-yield numbers. These are the facts you cannot afford to forget. For hypertrophic cardiomyopathy, the magic number is 15 millimeters of septal thickness for men and 13 for women. For dilated cardiomyopathy, the diagnostic cutoff is an ejection fraction of 50%, but the trigger for an ICD is 35%. For restrictive cardiomyopathy, remember, it is a disease of diastolic dysfunction, often with preserved pumping. And for arrhythmogenic cardiomyopathy, the arrhythmias appear before the pump fails. Memorize these associations. LG equals tissue characterization, and the two-hit model explains variable expression. Differentiation is where the rank is decided. You must be able to tell these apart. Differentiate HCM from athlete's heart. Athlete's heart regresses with rest, HCM does not. Differentiate HCM from storage diseases like Anderson-Fabry, which often have systemic signs. Differentiate RCM from constrictive pericarditis. RCM is a muscle problem. Constriction is a sac problem. And distinguish ACM from sarcoidosis. If the vignette looks like right ventricular dysplasia but mentions mediastinal lymphadenopathy, it is sarcoidosis. Finally, do not confuse simple PVC-induced cardiomyopathy with a primary genetic arrhythmogenic cardiomyopathy, as the management is completely different. Here is your quick reference for management thresholds. For standard heart failure therapy, we generally treat aggressively when the ejection fraction drops below 40%. For primary prevention of sudden death in dilated cardiomyopathy, we implant an ICD if the ejection fraction is persistently below 35%. But remember the exception we discussed. In ACMLV, we consider an ICD even if the ejection fraction is greater than 35% because the arrhythmia risk is independent of the pump failure. Also, watch for that 5% of HCM patients who progress to a burned out phase with low ejection fraction. They need heart failure therapy too. Cardiomyopathy is not a static disease. It evolves. We call this phenotype evolution. A patient with dilated cardiomyopathy can improve with medication, undergoing reverse remodeling, where the heart shrinks and function returns. This is remission. Conversely, a patient with classic hyperdynamic HCM can progress to HCM with reduced ejection fraction, developing a restrictive physiology and pump failure. The mid-range ejection fraction is often a snapshot of a patient in transition between these states. So, if an old patient's echo looks different from their young echo, it is likely the natural evolution of the same disease. We have covered a lot of ground. We moved from the basic definitions to the complex genetic architectures. The key takeaways for your exam are: diagnosis is now integrated. You cannot rely on just one test. You need the clinical history, the echo, the MRI for tissue characterization, and genetic testing. Your management is guided by the specific phenotype, whether the problem is a thick wall, a dilated chamber, or a stiff muscle. And finally, never forget the family. Understanding inheritance and the two-hit model allows you to save not just your patient, but their relatives as well. Master these concepts, and you will dominate this section in NEETPG. Good luck.